identify your champion and do what you're going to say you're going to do, be a part of it. Assess how you can participate in a community effort. Don't burn one staff member out in that role. Make sure you've got multiple people in that role. Step up when that leadership is needed, but know when there might need to be a more neutral party if you've got more than one healthcare system in your community.
Trying to determine what are our same languages, what are our shared languages, what are our shared scopes, and trying to find something, a frame to make the case to other sectors to come to our table. So maybe it's the language of equity, maybe it's the language of networks, or even the language of power rather than the language of health per se.
Recognizing that we're not the experts at every table, understanding that there are other experts that in our community that we need to borrow from, and that the people from the transportation or employment or housing or education, those are the experts in their field, and sharing that table so all those voices are heard.
I think we frequently speak the language of healthcare, but sometimes we really need to speak the language of equity or housing or food justice to make sure that we're meeting the community where they're at and other players that are all moving towards the same effort, and make sure that we're speaking the same language and working towards the same goals.
I think often there's a deference to the healthcare entity that, like, because they're either the ones who have the money or like the credentials or the power, and the ones with oftentimes the limited time, like there's a deference to that when that isn't always appropriate. And so like, I think when you're involving a healthcare entity as a group, like maybe a hospital network, or you're involving individual providers in the provider level, like really spending the time to think, like, what is it that you are bringing to the table specifically, as opposed to like just this sort of deference to the larger entity, or like, again, that necessity to be a key player all the time. My guidance and advice to healthcare entities who seek to be strong partners is for them to be deferential to the other groups and figure out where they need to fit in, not to take over or to squash.
Our healthcare institutions carry a lot of weight, and they're often connected to academic institutions, and a name like Jefferson, a name like Temple has a lot of respect in the community. So just sort of having their name attached to a project like this is key. And when it comes to funding or other requests, or sort of like shopping this work around for other partners and other, funding opportunities in particular, it's been incredibly valuable to have a name like that attached to the works. Depending on the institution and their priorities and their CHNAs and where they're aligning their resources, there could also be resources coming from the health network, and time, people power as well, to dedicate to the work, rather than just saying, oh yeah, we care about that, let us know how it's going. Fully investing because it's one of their priorities. So yeah, I would say name and financial resources are huge.
The advice that I would give is not to assume that you or your organization is the big draw. I think we've assumed that people would come to our table because we're the healthcare organization. But we've spent some time trying to map out who were the stakeholders that represented these different social determinants of health, so we could get them on board with us.
Do that, and so having a united way that's so embedded into the community, and then working alongside the hospital system and bringing those community voices in has been hugely helpful.
We need to use our power as a healthcare system to support the voices of the community. So how are we to use that power as healthcare institutions to support smaller organizations, community-based organizations, and communities themselves to elevate their voices in all of these discussions?
So I think when it comes to a hospital, you have to identify whether you have certain advocates or champions that really believe in the work. I think that's powerful. And I will say, in regards to our initiative, it's been really key to supporting it. As we rolled out our care coordination platform, their IT department and legal department basically vetted the entire platform for our community.
There are two ways that hospitals can really participate in this anchor network, right? And so, actually three. And three is not, the first one is not what we recommend. I mean, grants are great, so, and they're welcome, but they really don't, again, they don't really address those deeper root causes, right? The other way is that, you know, for hospital to invest in sort of this community benefit. They do the community needs assessment, and then they allocate a certain revenue that the hospital generated into the community needs. The third is the community building activities, right? And this is where the hospital reaches in it's in a different bucket, right? Their revenues, their reserves, and the land. And this is how they really participate in the community building.
So Yale New Haven Health is actually, right now, we're pursuing an anchor strategy to really make that be more intentional. But the balance of that also is, generally, hospitals tend to be in any town one of the larger employers. And that is good and bad. It's great because we have some resources, and it's great that we can do a lot of in-kind donations and work. It's also bad for two reasons. One, people sometimes think we are just there, can you just pay for this? Can you just give us money? And the truth is, sadly with COVID, we are not in that position. But also we have to really tread lightly and not be the large employer, the large health system telling the little CBOs what to do. And that is a balancing act.